everybody, and welcome to the second session of Raja and Neil's FASD book club. We are really excited to have this series going on. We had the first one a couple of weeks ago, and we had fantastic response to it. As you know, these sessions are being recorded and then put up on National FASD's YouTube channel. So by the end of this whole series of sessions, we should have a nice package of different videos that people can watch just to get, we're calling it kind of bite-sized chunks since it's lunchtime and we're doing these very quickly. I'm not going to talk a lot about it, but I think you probably know that it's all based on this fantastic book that Raja and Neil edited. It's called Prevention, Recognition, and Management of Fetal Alcohol Spectrum Disorders. And today, Raja and Neil are going to share with you some thoughts, and I'll just let them jump right into it. Raja, you're going to share?
Okay, cool. Right, so welcome to week 2. So this week is looking at pretty much chapter 6 of the group. So what we're doing with this is it's standardizing the approach to assessment diagnosis. So chapter 6 we're in the book is really an introduction to section 2. And so what we do is we start to give a background in terms of the historical aspects, start to put in some debate and consideration around physical versus neurological issues, thinking a little bit about the different diagnostic approaches, giving a little bit of history, so comorbidities, but then finishing with the so what question. And then what that does is section 2 of the book, and you'll have more of this in detail of some of the chapters going through, goes on to explain more of this in more detail. And so this chapter is really about setting the scene. It talks about where the journey began. So it goes back to in 1973, where Dave Jones and Ken Jones and Dave Smith were two people working in the First Nations populations in America, and they identified in some babies some facial characteristics, and they kind of attributed this and called it fetal alcohol syndrome, and that's all they understood at the time. And over the 50 years that have happened since then, the journey's moved to the point where we're no longer really just focused on facial stigmata, because we know actually that affects between 2 and 5% of the population. And actually the severity doesn't matter on the physical stigmata, it matters on the nature and degree of exposure in other areas. And it talks about that journey and where we've got to. That physical stigmata part, which Mario Miguel de Campo talks about, it's not just about that. There are lots of other things that you can look for, and actually the neurological aspect is increasingly recognized since the turn of the 2000s as having importance. And when we move on to think about the diagnostic approaches, that also reflects in our understanding there as well. Because if you go back when we first talked about this, the only description of people that people talked about was full fetal alcohol syndrome, and that's because that's all they knew. And that was to be talking about 50 years ago. By the turn of the century, not turn of the century, by 1978, you're starting to talk about fetal alcohol effect, where people are starting to recognize, actually, do you know what, there's more to this than just the small little bit of the syndrome that people talked about. And in 1996, the Institute of Medicine, which is the equivalent of the Academy of Royal Colleges, came together, and they created the first diagnostic approach to try and standardize this. And they talked about their fetal alcohol syndrome, partial fetal alcohol syndrome, alcohol-related birth defect, and alcohol-related neurodevelopmental disorder. Even that wasn't enough. And so Susan Astley and Sterling Claren developed the 4-digit scoring system, which tries to think about the effects of prenatal alcohol exposure in its whole context and the whole span of presentation that you can find. But it became considered quite unwieldy in some situations. There's 256 codes, you have to follow a certain process. And so the Canadian group, again, 2005, pulled together a set of criteria, and again, but using the diagnostic criteria set out by the IOM. DSM-5, which was the first psychiatric statistical manual, started to say again, well, how do we do this as single practitioners? How do we start to define it? And we had a series of workshops that led to the Time Is Now document, where we spent a lot of time thinking about single practitioner versus multidisciplinary team approaches to this. And at the moment, there's an international collaborative looking and thinking about where cutoffs should be and shouldn't be. But where we've ended up is that recognition that fetal alcohol spectrum disorder is a condition, and the severity isn't defined by your stigmata. It just is one of those characteristics, you have it or not. It makes it easier to recognize. It doesn't make it more or less severe. And so that is where we're at, because FASD is now the diagnostic term that we use. And we also, what's interesting is if you look at the debate around it, we argue about the minutiae. We argue about, should the cutoff be 1.5 standard deviation? Should it be 2 standard deviation? Should there be 3 criteria? Should there be 4 or 5? Where should those things fit? But we all agree that prenatal alcohol is a tragedy. We all agree the broad parameters, and we all agree that this is a thing that needs to be worried about. And so when people who don't understand the debate that's going on have that narrative, they try and say, well, actually, you guys don't agree. Actually, we do agree. I sit on a table around from people like Ken Jones, Susan Astley, sort of Jean Hoyme. These are people I know well, and we sit around a table, and yes, we argue, and yes, we go into the minutiae, and yes, we were trying to do it. There's a meeting this evening looking at that again. However, it is very much the case that in the broad parameters of things, we agree very strongly. And that's important that people take that away. Now, the other thing is then, well, okay, if you all agree, well, why don't we see it more often? And that's because it presents in such a broad way. In the Lancet paper that I was part of, we talk about, is that 428 different comorbid conditions. It's because they are so variable in terms of that, but also it's a condition which is etiological. We have to rule things in and rule things out to get the right understanding. And therefore you need to compare it to the right things. And the chapters start to go into that. And we kind of set that out here in this chapter, saying, well, actually, do you know what? You can't just take it as being FASD as compared to this, that, and the other. You have to put it in its right context, because actually by understanding its importance, understanding where it fits into the bigger neurodevelopmental world, actually increases its importance of understanding, not diminishes it. But not everybody sees that. And that's one of the things that we need to be able to think about. And the chapter really finishes with the so what, because actually we hear this so often, is what's the point of making a diagnosis? And I had somebody recently from a very high senior position within the NHS asked me exact question. And the point being is that if you don't understand that this is an etiological condition, if you don't understand that it has a different profile to other etiological conditions, even if it has that comorbidity of, say, ADHD and ASD, even if it does, it's different in its profile. There's a different way of managing it. You have to understand that in order to best formulate the needs of that individual. And we know that the NICE quality standards, quality standard 5, is you have to have a multidisciplinary plan to help support that individual going forwards. And if you can't understand it in its context and you take generic approaches, you're not going to understand that person. We also know that there are more interventions coming, and we know that there are things down the line that will help with all of this. And so what we start to do is to address some of that. And the chapter is a short introduction which sets the scene. And then the subsequent chapters in section 2 start to address more of that in more detail. And they will come in some of these future book clubs as well in terms of the detail of that. So I'm going to stop talking there, and I'll let Neil come in and add to that. Do you want me to stop sharing the slides, or do you want to slide up?
No, it's fine. I don't have any additional slides to say. I was just going to just really say that although there are different diagnostic classifications, I think reinforce the point that the fundamentals are ones of agreement, not disagreement. And that although the 4-digit classification perhaps started off as the most comprehensive initial, it's quite complex. It divides into lots of small groups according to how children present and exposure and those sorts of things. And I think is a really powerful kind of potentially research tool for those who are into the minutiae of that. But actually fundamentally, when you're trying to roll out something like an understanding about FASD to the wider population, to be consulted with a manual that is spiral bound and is over 200 pages thick and contains 256 different codable subtypes, people's approach to that was just like quite understandably. And so I think the adoption perhaps of the Canadian approach initially in this country through the Scottish sign guidelines, and then probably that was also the basis on which we took forward the FASD quality standards with a similar sort of approach, I think does make a slightly simpler way of approaching the diagnostic pathway. But of course, we're really interested, and it's apparent from families, from those who have been affected, that early diagnosis is so important. And of course, we've got this issue of trying to kind of pick these things up at a much earlier stage. And perhaps, the missing link we might have in this country, which is not to inhibit all of the things that are developing and that we're doing to try and roll out diagnostic pathways and training of professionals, which is now amazingly in progress. But the missing link is the what do you do with those who are identified as having potential exposure during pregnancy, and then, but they're not yet, when diagnosis is so profoundly based towards the issues of neurodevelopmental problems that might appear much later. And so in a way, it's that there is an issue that I think we need to acknowledge about that link, and the potential that I come across as a baby doctor, really, with looking at babies that I know have been exposed, that I'm unable to send on for further referral, because many child developmental assessment services won't or aren't commissioned to accept babies who don't yet have what is identified as a problem. So, and that's very interesting, because as a neonatologist, our whole ethos is enshrined in neonatal care, perinatal care, in follow-up of babies at risk, and 10% of babies are born preterm. And those babies who've been through and had a significant exposure to neonatal intensive care, or indeed prematurity, or low birth weight, or some problem that's happened that's made them at risk of a future neurodevelopmental problem, such as infection, that kind of follow-up is enshrined into our clinics. But of course, it doesn't exist within the neurodevelopmental services. So I mention that and I talk about it because it is a potential issue, and it is something which I hope that we will in time be able to address. And I find it sort of slightly ironic that the first paper and the presentation about fetal alcohol syndrome, which Raja alluded to at the beginning, with that first paper in the Lancet in 1973, was about babies. And yet actually it's quite difficult to make a diagnosis of FASD in babies at such an early stage, so that there is a slight irony there. But as we've understood much more, I think most people would agree that it's the complexities of how that prenatal exposure has affected the nervous system that really is the thing that perhaps is most life impacting, and I'm sure others can comment much better on that than I can. But I think, interestingly, as we talk about diagnosis and diagnostic assessment, and at the moment there's real pressure to kind of get all that in place and to actually for people to get diagnosed, there is also another ongoing issue, which is, Raja's talked about the multidisciplinary assessment and the understanding of the complex needs of each individual as being unique. They all have a unique fingerprint, a unique way in which I suppose their difficulties might present, or the help that they might need, for example. But I suppose what we haven't really addressed also, and I just highlight this as another potential gap for the future, is that those needs will change, and perhaps it's not just like you've got a diagnosis and that's it, but actually sometimes repeat multidisciplinary assessment is likely to be necessary as children grow up and present with different issues, different problems, and through the life course, and then on into adults. ... I'll leave that box blank for now. So I think those are kind of some of the issues that I think we tried to look at, and I think overall in the book tried to come across and get authors to talk about the varieties of the different ways that the presentation of FASD can happen, because that helps to widen people's perspective into the approach, and that things aren't just pushed off, or just, assigned to some other problem or some other issue, or its behavior or its parenting or its attachment and all of these other things. And I think sometimes the problem that I see in the pediatric world that people don't understand is children that can have really quite significant life impacting the ways that it affects them, I suppose. Sorry, I'm not being very articulate there. The ways that it affects them. But yet, on the other hand, they don't actually reach criteria for formal diagnosis through the current neurodevelopmental pathways, such as ASD, autistic spectrum disorder, or ADHD. They have some of those things in those areas and so on, but actually it's much more complex. And this is sometimes, I think, where the difficulties and problems of children, both within education and within health, but probably struggle to be dealt with because we're not meeting those criteria. So I think those are probably just a few of the issues and problems that I would highlight, and probably need to stop talking there.
Well, that's great. Thank you, Raja and Neil, both for outlining the issues involved with standardizing the approach to assessment and diagnosis. It's evolved over time and it will continue to evolve. I think that this is a nice little snapshot of some of the issues to come in future book clubs. And just to say that the next session is coming up soon and it's going to look at alcohol in pregnancy. And the one after that is going to talk about how our understanding of FASD has progressed over time. So this is an ongoing series. I'm going to stop the recording now, as I mentioned, and we're going to then go into a brief Q&A. So thank you to Raja and Neil. I'm going to stop recording now.